Professor Arnold, and I'm very glad to have a teacher like you, and it is very nice to hear these very touching words from a mentor. It's true. I'm delighted, ladies and gentlemen, to present you today a proposal of two multi-center RCTs regarding prevention, secondary prevention, in risk of patients at preterm birth. I don't want to repeat the existing literature. We all know the data set, but in order to get an overview, especially about the methodology, I'm a bit anxious after this excellent presentation of years of courage today to talk about methodology, but it is very important. And I'm going to tell you some things about the existing literature and their methodology. Meanwhile, it's a gold standard in the diagnosis and the prediction and the accuracy of preterm birth delivery, and that we perform a transvaginal ultrasound and measure the cervical length. I just show here the reference curves because they are relevant for the study proposals. We have the reference curve from Salomon and colleagues from the 16th week upwards. For twins, to the best of my knowledge, there are not existing any reference curves, but I found in the twin textbook of Professor Klickstein a chapter of Professor Arabin with his box plots from the 14 week upwards, and we could take them into consideration for our trials. The probability to detect preterm delivery is better if we perform the diagnostic at an early stage. For example, in singleton pregnancies, it is better, the accuracy is better if we perform the transvaginal ultrasound earlier than 20 weeks. With a cervical length of 20 millimeters, we have likelihood ratio of fast 15. And after 4 weeks later, the likelihood ratio is falling down at 5.
We are shocked because of this data.
Well, I can understand this.
And if you think we fell asleep, it's not true.
Okay. And in twin pregnancies, it is 60 in the likelihood ratio, very high before 20 weeks. And 4 weeks later, it's falling down at 3.44. So the earlier we perform a diagnosis, the diagnostic procedures, the higher the accuracy. A very nice work has been recently published by the group of Melamed and colleagues, and they compared transvaginal sonography once in pregnancy, 20 weeks, versus 2, 3, and 4 times. And if we perform one transvaginal ultrasound for cervical length measurement, the area under the curve is 61%. If we perform 4 controls, the area under the curve is approximately 92%. Therefore, this is an important clinical approach we would like to imply in our future studies. And here we see also this is important for the accuracy, because these are pregnancies delivered under 32 weeks, and these are pregnancies delivered after 32 weeks. And we see here the difference is much smaller than at 32 weeks. The gap is getting greater. Meanwhile, our understanding how pessaries work has also been more evidence-based since the publication of Kani and colleagues. We know also in images how pessaries work. They change the inclination of the uterocervical angle, and they are thought to create also an immunological barrier. And this is a big difference compared to vaginal cerclage. because we have the inclination, and however, the vaginal discharge can be can go away. It doesn't. The bacteria doesn't stay in the uterus. Another novel procedure and possible indicator for pessary treatment is the uterocervical angle. We know that if the angle is greater than 105 degrees, then the risk for a preterm delivery is also higher. And in these cases, we could consider if we will apply it also in our studies. There are also reference box plots regarding the uterocervical angle, published also in this twin textbook of Professor Blickstein from Professor Arabin, and we can take them into consideration.
New ones in the American journal.
Thank you. I don't want to repeat the data of Maria Goya, we all know them. It is, however, very important that they place the pessaries after audits and teaching. And especially in a technical, in operating procedure, it is very important to perform these audits. I must certify myself if I want to measure the nasal bone or the nuchal translucency scan. This is a diagnostic procedure. Then why not also for an operating procedure? There's also a retrospective comparison published by Professor Alfirovich comparing all three methods for the secondary prevention of cervical length. It is important, I just show it because it is important, because they also had cervical shortening and a risk pregnancy because of history of preterm birth in the previous pregnancy. And the pessary was in this study associated with an even lower rate of preterm delivery before 34 weeks compared to progesterone. Another study investigated pregnancies with history of preterm birth in earlier pregnancies without cervical length shortening, and they didn't find in this setting a significant reduction of the frequency of recurrent preterm birth for progesterone. Another clinical approach we are going to apply in our trials. This is the dataset of the outcomes of the PRO-TWIN trial. I just show it because although the results were significant, especially in the neonatal outcome, which is very important, composite poor neonatal outcome and death before discharge, the authors performed also a censoring of the cases before and after taking out cases with mismanagement. Cases with mismanagement were, for example, an iatrogenic removal of the pessary because of vaginal discharge. And they found an even larger reduction of poor neonatal outcome and preterm birth after censoring of the cases. And so the treatment effect is even larger when pessaries were consistently applied. This is a retrospective study of the Spain group, and they investigated monochromatic twins after laser treatment who received pessaries. These are very, very high risk pregnancies because they have a risk of approximately 50% lower if they have early cervical length shortening. And we're currently also recruiting in Frankfurt patients in a randomized control trial. These are the results of the Goya twin study, the PESIC twins. They screened 2,300 twins, and of them 137 had a cervical length under the 25 centile, which means 38 millimeter. And they found a reduction not only in preterm birth delivery under 34 weeks, but also in the birth weight at 2,500 grams, which is another important parameter, at least in Germany, in order to observe the baby in an ICU unit or not. Unfortunately, the only studies could not show significant results at any level were the studies of the FMF, the multi-continental studies of FMF. I would like to criticize some points here. Over 40% of patients were simultaneously treated with progesterone. This is an additional confounder, so this is a treatment bias, strong treatment bias, and over 1/3 of the patients received antibiotics because of vaginal discharge without having any infection. In this context, I would like to show you also the reply of Professor Nicolaides to Maria Goya, where he admitted that the doctors taking part in his studies, they didn't receive any supervision. And we should also know, at that point, we didn't have any protocols. Maybe some of you know the Proteus phenomenon. Proteus, or the Proteus of Greek, sorry, was a Greek god in Greek mythology, a god with many faces, Greek god of the seas, and there exists the Proteus phenomenon in statistics, and the authors could show that early replications of studies after the original studies could lead to a bias against the result of the initial publication. And I just showed you this because there are many teams in the studies of Nicolaides worldwide, and you can't control all of them. And that's a real work. But after the publication of Goya, there was a run to collect patients and publish results on pessary treatment, and in many cases the methodology was not correct. We call it in Germany a clean work, clean study.
What I said, that's the real world. If you will apply the pessary, if all of us will do it, it will be the same as real life. Because we are not in this specific research session where it's done very reliably, very well.
Well, you can have, like in ultrasound units, you can have some published preterm birth clinics, and considering what preterm birth does, I think we should control patients with a risk of preterm birth in a continuous setting, and not just do a cervical length and send them out. That is one. And what makes me a little bit sad is that Kypros himself published on nasal bone and nuchal translucency standards, and he demands standards and audits. Even me, as a Degum 3 person, I have yearly to pass an exam for the stupid nasal bone and nuchal translucency measurement, and then my results are good. If I would like to ask all my oncologist friends to do the nasal bone is of no valid. And that is what you want to say.
I would like to present you two cases. Yesterday, we had a patient who came to us for a second stage ultrasound, 20 weeks, and the doctor has placed a ring pessary for incontinence. The small ring for incontinence. And she had a cervical length of 6 millimeters with a great funneling. And it's logical that it can't work in such a case. And a second case of the dream trial of Nicolaides was, for example, a patient where they could not remove the pessary by pushing back the cervix or by cutting the pessary, and the patient received a general anesthesia. So it is important. It is important to teach everybody in a small work group. It must not be more weeks.
The worst case is the pro-twin trial, where in the pessary arm, doctors, because they were not taught and placed the cyclage, and one woman died from the cyclage. But because it was in the intention to treat arm of the pessary, you had a maternal mortality in the pessary arm.
And just like in every intervention, in every operating procedure, its pessary placement is uncomplicated. But there is a learning and confidence curve. And a year ago, we were in Crete, in the FMF World Congress, and Franca et al. Have presented this very nice abstract, and they investigated patients receiving pessary treatment at the beginning of the study and at the end of the study. And they could show that the results could significantly be improved within only 4 years. Last not least, this is the cover, the best example of the American Journal of Obstetrics and Gynecology, with the artistic picture of pessary, which was set upside down. And nobody commented on this. And apart from this, there are also pessaries who are being moved during pregnancy, and they rotate upside down. It's so logical. We should control them. So, apart from this, there are also long-term effects of pessary treatment. Similar findings are not available for cerclage or progesterone treatment. They've been published by the group of Van Hoft in the SMFM Congress this year, and they could show that the children at 3 years of age had a higher survival without disability. This is very important in the pessary group compared to the control group. An important clinical outcome, long term. Now I would like to show you 2 specific proposals, one for singleton pregnancies and one for twin pregnancies. And I would like to share them with you and discuss them with you. This is only a preliminary proposal.
Before you do that, can you just tell us how people should be trained in order to be allowed to participate in this trial?
Online.
No.
What do you mean by online?
Objection.
Well, I think if people had never done ultrasound and you show them online a picture of the nasal bone, can they do the nasal bone? I think once they should be at the monitor, and because when I teach hands-on.
You have been passionate about the training, and I entirely agree with you. Kypros was also passionate about training and then created a system of training.
Yes.
In my clinic, I've been doing insertion of arabine, and I consider myself a experienced pessary inserter. I have no certificate to show for it. Nor when people come to me, I don't know how to train them. I can show them the YouTube video that Maria has produced, but that is not good enough. So what I'm saying, we need to kind of put some work in it. So what I'm looking for, if you're to standardize the treatment, I'm entirely in favor of this. We are now doing the trial, which I can tell you a bit about. So what I would like to see from Clara Angela Foundation a model that I can buy to do that, or to some standardized treatment, because my first question is going to be, how are your operators going to be certified for this trial?
No, but you just go into the next room and there is the doll and the vagina and the cervix, the workshop. That would be a workshop for development countries for, let's say, 1 hour each, practical, because it's not more difficult than that. And then online, a list of questions did you consider 1, 2, 3, 4, 5.
So this is going to be so that is going to be a teaching package.
Yes, before.
It's the same, just like bridge delivery or vaginal extraction, vacuum, of the model. We are having workshops. I had workshops, and then I have experience on patients.
So are you going to say that if people have completed the module, and therefore then carry on inserting the Arabic testing, then we are going to be saying they have been trained to our satisfaction?
Would be my proposal.
Good.
But the thing is, reality is that somebody inserts it in this trial, and then this patient is sent to the private gynecologist back, who never had heard, at least in these trials, of the pessary. And then when the woman has discharged or really preterm prom or contractions, they don't know what to do. And that is what happened in these trials, I think.
And then I'm not going to interrupt you anymore, but I'm just going to go back to Jerry's point. Then you need to decide, and we need to decide, is this a trial of world experts who are the top experts in pessary removal, insertion, or whatever, or is this a pragmatic trial for real world that Arabic pessary is going to be done, if this is of benefit, by normal people? You have heard the ultrasound debate. Those are all the relevant questions. You can talk about ultrasound done by Arabic or ultrasound done by normal people. But these are two different questions, and you shouldn't be mixing them together.
Yes.
Kypros Nikolaidis' trial was different, asking a different question. What happens when Maria Goya's results are left to the real world? That's what happens. If you want to send all your short services to Barcelona with EasyJet, for them to be done by Maria Goya, then you use Lancet paper. Those are two different questions, and they are not right and wrong. They are just different.
Yeah, it's absolutely true. Yeah. The first study is considered to be a multi-center randomized controlled trial with early pessary treatment to prevent high-risk single-twin pregnancies. There are now two possibilities. We would like to recruit patients with a history of preterm birth. This is a risk group. Recruitment is considered to take place from 11 to 16 weeks. We have considered earlier, a year ago, to recruit patients in the first and only in the first trimester, but there we have the problem of abortions or other problems that the patients are being treated only in outpatient clinics and not in our hospitals, and therefore it would be very, very difficult to recruit them. Therefore, we would like to recruit them from 11 to 16 weeks. The big question is now, if we only consider this history, these patients with a history of preterm birth, or if we also take pregnancies with cervical shortening. The risk is modified. The risk for preterm delivery in the index in the current pregnancy is modified by the history of preterm delivery. For example, if a patient had a preterm delivery, only one, and she is now in the second pregnancy, the risk is 17.2. After 2 preterm deliveries in the 3rd pregnancy, the risk is 28.4%. If the patient had a preterm delivery and then a term delivery, then the risk is reduced at 5.7%. Therefore, my suggestion is to consider only pregnancies who had a history of only preterm births and not one term birth in the history.
So what you're saying that if I had a 24-weeker and term pregnancy, then I'm not eligible for the trial.
One more time.
Yeah, he was saying that, but I don't think it's okay.
But then you said that one term birth excludes you from being a high risk. So I had in my first pregnancy I had a 24-weeker preterm birth, and then I just happened to be very lucky and had a term pregnancy. I would not be eligible for the trial.
No.
Really?
Because we had a modification of the risk, and then the risk in 3rd pregnancy is only 5.7%. Maybe it was infection or another cause, and there is
so after 5
completely
years,
other.
so you do the trial and show that pessary works for women with previous preterm birth. I come to you with one history of preterm birth and one history of term birth. Are you going to say, I'm sorry, I have no data for you? You are not going to treat me. Because you're going to say that all these 5 years worth of effort that you have produced is not relevant to me.
I'm going, in this case, I'm going to perform a transvaginal ultrasound and see how the cervix is, the cervical length.
Why not taking both, taking up 2 arms, taking both, and have a competition team, how it works for the 1 term and for 2 terms of pregnancy?
In this case, we should power the study in a completely other way.
Stratified.
Where are these data coming from? I mean, clinically, I think clinically we all doubt the 28% ranking. You've got less than a third chance of a preterm delivery after continuous 2 preterm deliveries. That sounds very low.
These data come from the Oxford reference book of Professor Adam Kummeran. They're relatively old, 20 years old, and were published by Hoffman Oncologists in 1995. And since then, I haven't found any data yet.
Well, it's still debatable.
Yeah, exactly.
So
Bring them all in.
Because that would mean if you anyway have a 17% chance of preterm delivery after a single preterm delivery, it's if you don't do anything, the chance is less than 20% anyway. So why bother with the RCT? Why bother with the pessary? Because you will need a huge number of patients to recruit to top that low percentage anyway.
Let me show the next diagram will answer the question. We have performed power analysis with Professor Hermann, he's the ordinarius in Frankfurt. And we have considered that we can recruit a little bit more patients with a history of preterm birth compared to cervical shortening, because they're mostly cases being treated in outpatient clinics, and it's a little bit difficult to come with them. In this case, we have the screening group and the risk group, and if we consider the 17.2%, not the 28%, 17% with the risk group, and the screening group with 35%, this data has been extracted from existing literature, then we need only 540 patients. It is very important also to power the subgroups in order to show that, in order to publish them also separately, to have a powerful analysis for the subgroups. And the risks will be modified if we change the protocol.
So to show what? What do you want to see?
Our goal is to prevent preterm delivery. This have been calculated to prevent preterm delivery at 34 weeks.
To zero, that's meaning it's 35 to 0.
No, 20%.
20%.
Anything, and your control group is no treatment.
No treatment. In this case,
And you think that in Germany it is going to be possible?
it will not be possible. Progesterone will come.
So how are we going to do the trial?
This is a problem. Therefore, we there.
Second group would be down to 0 then. 17% only, 20% difference. Yeah, but you know,
The
it
second
depends also when the first preterm birth was. Because progesterone probably does not work when the preterm birth was between 26
They
and
won't receive any progesterone.
34.
Only the screening group.
Only
Here
when
it's
the
not
preterm
indicated.
birth was very early, progesterone seems to work or might work, I don't know. Just on risk. I don't talk on screening. On screening it works. Then, well, it's a question of compliance of your participants.
I think unfortunately the time for the trial that is going to have high risk for preterm birth group untreated completely, the window of opportunity for such trial has gone.
Yeah, at least in our countries.
I think in Western world, I'm not necessarily saying that I agree with it. I'd love to see it. I just don't think how ethics committees in Western world will say to you, you have a woman who had 2 previous 24 weeks and a short cervix, and you're going to give her a cup of tea.
No, that is not possible. We all agree. The question is, when she comes at 12 weeks, she has normal cervix, she will get a pessary or nothing, and the control group will have follow-up. And as soon as the control group has also cervical shortening, the control group will get the standard pessary or progesterone, whatsoever. The thing is, I mean, what we were talking about is what to do in countries where where women have already lost a child, but they have no hospital doing all this sophisticated follow-up. So can we then convince, is it maybe a simple tool for these developing countries, at least in those women who have lost already a child?
The next problem
That is the question.
if someone
Or
comes,
if for our countries, is it because, you know, frequently women come too late, they have funneling, they have already a very short service, and then I think pessary, when they have also contractions, does also not work.
this is true. And the next question is, if we see someone at 12 weeks in the high risk and with normal cervical length, and she comes at 20 weeks with a funneling or cervical shortening, what are we going to do then? That's the next problem.
But then you're risking. So basically, you're talking about 2 different treatment strategies.
Yeah.
That is completely different. That is not anymore Arabin versus no Arabin or progesterone versus no progesterone. What you are now talking about managing high-risk women with different prevention strategies.
Yes.
So that is a trap. And
Yes.
this is one for high risk, for high risk of settings like Germany and UK, and one for Africa.
Yes.
So we need to be clear what we are talking about.
Yes.
Forget about Africa for the time being. Talk about 2 different strategies here. What you are talking about is one is going to have primary treatment with Arabin pessary immediately, whatever is going to be the trigger, and the other one is going to have a follow-up with ultrasound and only treated with a short cervix. That is a reasonable trial to do, but you're going to have tens of thousands of women because you cannot quote this, because you have both groups treated differently, but treated.
Yeah.
So therefore your differences are going to be tiny. You don't have any more, like Goya and Kypros, 15mm short cervix untreated, treated with a placebo. That has disappeared. And this is the reason why his pessary trial was negative, because everybody was getting progesterone.
Yeah.
So you're basically going to be repeating progesterone treatment controls with Arabine treatment in the other group. And therefore you have 99% chance that you're going to have negative trial. Because you have both groups treated, but differently, which is fine. And that is the trial that you are doing.
But in fact, maybe, well, we all know as clinicians, also when we follow patients every 4 weeks, that it happens all of a sudden. The cervical length goes from 3 to 0. So by prophylactic approach, you might, they have anyhow a high chance to get treated. Why not early? There was also this abstract at the ultrasound congress. I mean, for the woman, she can have intercourse with the pessary or without. And that was the question. It's the same cost. It's just to be early.
That's a legitimate question, but it's a different trial. So then you say, if you are what Bina is saying, what I think, what you're talking about, if you are high risk, for whatever reason, previous history, whatever, conization, 1 preterm birth, 2 preterm birth, 5 preterm birth, doesn't matter. As soon as I see you, I will put pessary. Doesn't matter. And see what happens. That is what you are talking about. And then you can look whether it matters whether I have 1 preterm birth, 2 preterm birth, 1 loop, 2 loops, 3 loops, whatever. You're saying if you're high risk, by whatever clinicians say, whatever you think the risk is, we'll treat you. And the other group, no, we think this is silly, we are only going to treat you if you have short cervix.
Yeah.
And positive fibronectin or some fancy electronical cervical thing, whatever Americans are now developing, and there's going to be many others.
Yeah.
And good luck with the trial because you need 10,000 women to randomize.
It's never something.
I'm sorry, just a short comment, if possible, regarding that. Maybe, I don't know, maybe it's a stupid idea, but just as an idea. For today, we're pretty sure that shortening of the cervix is connected to preterm birth. So maybe it will take, and not very strong, but still an outcome, like a cervix shortening. Meaning that we will see 2 groups with risk factors, with pessary and without pessary, and then we can check if in the group of pessary the cervix shortening was rare or more often situation.
But this is surrogate parameter.
Sorry?
This is surrogate parameter.
I understand perfectly, but in this case, I think it could be an option to not to have that another group that will be treated with progesterone and whatever. But maybe just an idea that you can think about. I understand that surrogate parameter is not very good as a primary outcome, but maybe it can be a first step of like how to manage to skip the situation when another will be treated. Maybe to
serial cervical measurements and measurements of the uterocervical angle will be conducted. This is not the main issue of the trial. The issue is to set the primary outcome and set the population. This is the difficult part.
okay.
Thank you very much.
Can I ask one more question?
Yes.
It is not very clear for me. When you say patient with a short cervix, do you mean nulliparous patient with short cervix, or will you include in the group of patients with short cervix also people with a history of preterm
No,
delivery, or
these
they
are-
will be completely split?
These are two completely different groups, or, not and, or.
Okay.
And under the fifth centile.
Okay.
Sorry.
So my next question is, in the patient with a short cervix, will you also consider other factors like not history, but for example, infections or anything like that before sending the patient to randomization, or will you screen them for a
If there is an
urinary tract
infection,
infection?
I wouldn't place a pessary. If I have an infection, I would treat the infection first.
You know, the question is, what is infection? I mean, in all these studies, infection is not discharge. And
Yeah.
we have the study of Romero showing that all the microbiome does not correlate to preterm birth. And all German gynecologists do pH measurements and give them Vagi-Hex and Vagi-Flor and treat the so-called infection, which is in fact only colonization of normal bacteria.
I was just meaning a positive midstream urine sample or a positive cervicovaginal swab, not really the discharge.
But I understand your comments. The window of opportunity is gone in the screening group. Study number 2, also multicenter RCT with twin pregnancies and short cervix under the 25 centile. We're going to build 3 groups, 16 to 20 weeks, 20 to 24 weeks, and 24 to 28 weeks. The risk of preterm birth is in all 3 groups approximately 50%, and the expected reduction through pessary is estimated at 35%, extracted through the existing literature. And this is the preliminary consort diagram. We're going to randomize them. We're going to perform initially serial cervical length measurements. That means if the cervical length is here 4 centimeters and here 3.5, we're going to randomize the patient here in the second group. And they will be randomized pessary versus no pessary. We have the advantage in this study that progesterone is not indicated, and we will have, we hope that we'll have clean results. The estimated total number needed to randomize is estimated at 300. And any questions?
300 per arm.
No. All together.
Of course, yeah, sorry, yeah.
Monoperiod or diperiod?
Wow.
All of them.
Uh-oh.
It can be by.
Careful. Only
You'll end up with TTS and IUGRs and all monochorionic pathology that may, like monochorionics are different beasts, really. What is the cervical length below 25th centile in Germany for twins?
It's a good question. Also, other trials have taken the 38 millimeters, extracted, however, from the reference curve of Salomon for singletons.
No, yeah,
So you have to determine it yourself.
No, you have, in fact, when you contact the Dutch, they took their own centiles, but they never published them. So 38 is only between 16 and 20 weeks. And between 20 and 24, it will be maybe 32 or
38
34.
is for 16 to 20,
Yeah.
yes.
And then between 24 and 28, it will be 30 or even less. So what I do clinically, I mean, when there's crossing of centiles, then when there's a rapid decrease, then it's dangerous. And that is what we do. When we have a normal cervix between 16 and 20 in risk patients, whether it's a singleton or a twin, we do another measurement when she comes between 20 and 24. And then another. So I think this is just to translate what we do clinically into the trial.
But we don't know. We don't know what, if you're going to be randomizing, you do not know what is going to be how many millimeters do I have to be in order to be randomized at the moment. So is there nobody in Germany who can scan quickly 1,000 twins? Just sort of quickly?
But I have
We have a lot of
this
twins,
data. I I have no data from Dutch
So what we want this being, instead of this we want to say 32 millimeters, 28 millimeters, 24 millimeters, based on German data, because we in the UK, as you know, are doing Stop It too. We took the data from Kypros or whatever and found out that we got it wrong, because our 25th centile was we need to change it because we couldn't recruit any patients or whatever.
But what kind did you take for Stop It?
Well, because we wanted it to be 25 now we moved it to 38 because there was nobody, so we needed to increase. We had too few patients, and in Dutch, when they did it, there was nobody in Holland had a cervix less than 40 millimeters.
Yeah.
So I think you need to have, before you start, you need to have your own, German-based data. You need to know what is your 25th centile. Don't use Dutch data in UK data.
I think this is not relatively easily. We would like also to perform a clinical investigator protocol. And here we have already discussed about the certification and the audits and the teaching. A proposal would be, for example, the submission of pictures before and after insertion of pessary, with the elongation of the cervix or the change of the inclination of the angle. Another question is the correct placement of pessary according to good clinical practice. Is the pessary correct placed? Is it rotated? Did the doctors reassure the patients that vaginal discharge can be normal under pessary treatment? How is an infection defined in your patient? Management of PPROM and contractions, and how are we going to remove the pessary? And these are all subjects of this clinical investigator protocol.
Yeah, mainly just, sorry to interfere because I don't want to interfere with the trial, but with the practical management, there's now a publication, and also there were complaints from the Netherlands that you can hurt the cervix, and that is of course true when clinicians don't remove the pessary when the woman is in labor or when she comes late with contractions. And when the pessary is stuck, it is very easy to take a scissor, which you use for episiotomy, and just cut the pessary and not pull and with violence.
Or push the cervix back.
That is very, but you know, maybe in this moment, a resident who is on duty, he does not dare to cut. We have to communicate, and when I did not know when I introduced that all these simple, very simple things, and sometimes I feel ashamed to pronounce them, have still to be communicated.
Have you got any patient-centered outcomes like you? How does it feel like to wear pessary or
Yes.
From my clinical experience,
No, patients.
Yes, we have questions. There are questions.
And perhaps as a window, because you've got a unique sample of women, and 300 is quite a lot of them, ask some questions like whether pessary prevents some urogyne problems as well, like stress incontinence. I mean, it supports the cervix and the bladder neck, perhaps have this done at the same time. I mean, it's a completely different outcome measure, I'm sure.
it's a secondary outcome measure.
But
Can be
the
defined.
option.
And Janis, for how long will you investigate the children?
Also we have now the 3-year results, but as long as possible, I believe.
That, yeah, but you must be clear about that.
Just as said, also, there are no protocols existing. I'm writing the protocols since last week, and I see the future in networks for prospective studies. If we want to go far, we should go together. And prospective meta-analysis, audits and clinical investigators' protocols are necessary in these studies. And we should consider the quality criteria in order to avoid selection and treatment bias. Thank you very much.